So I'd like to start with a story. This is a story whose full meaning will become clearer as our session unfolds. It's about a young lady named Alexandra who woke up one morning and was getting ready to take an exam. She lived in an apartment in San Francisco, and her roommate was getting ready to go to work. And the roommate left, went downstairs where a boyfriend was waiting to take the roommate to work. So the roommate gets in the car, and the boyfriend is wearing shorts. And the shorts are wrinkled. And this displeases the roommate. And she says, we're going to go back inside, and I'm going to iron those shorts. So, as you can imagine, the boyfriend resists, but the roommate uses her magical powers of persuasion. And next thing you know, they're opening the door to the apartment. And there they see Alexandra flat out on the floor. She has no pulse, she's not breathing, and there's no heart rate. So they call 911, and 911 coaches them through administering CPR, which, if you haven't heard recently, the new protocol for CPR is you don't need to do mouth-to-mouth resuscitation. You just need to compress the chest hard and fast, about 100 beats per minute. It turns out that's the to the tune of staying alive. So they do that, and the paramedics come, and they administer those paddles, and they shock Alexandra's heart back to life. And then they take her to the ER, and at the emergency room, there are signs like this one. This is a matter of life and death. Time is of the essence. Everybody slow down. So we'll come back to this later. But at this emergency room, they do slow down. In fact, they put Alexandra into a medically induced coma. And they cool her body temperature to 92 degrees. And what this does is the body goes into this kind of system where it preserves critical functions of the brain and other vital organs. And that's why in places like Minnesota, you can pull people out of freezing lakes and then reanimate them. So there's an expression in emergency medicine that you're not dead until you're warm and you're dead. So they put Alexandra into this coma for 3 days, which is an incredibly agonizing time for friends and family. But she does come out of it. And when she comes out of it, I went to see her in the hospital, and it was a miracle. She had all her cognitive faculties and was regaining all her physical faculties. And she said to me, this has been a miracle. It's a miracle that I'm alive. But I'm not out of the woods yet. I still have some difficult decisions to make. And she described how one of the things she needed to decide on was whether to have a defibrillator implanted in her chest. And it turns out, as she said, there were some upsides and downsides, the downside being that this defibrillator could go off on a false alarm. And depending on what you're doing at the time that it goes off, that could be life-threatening by itself. On the other hand, if she was ever alone again and had another incident like this, the defibrillator could go off and save her life. And she said to me, I never imagined that in my 20s I'd be making a decision like this. And then she said something that was really, gave my work and my life so much meaning and was so complimentary. She said, it's okay though. Thanks to you, I know exactly how to make this decision. So why did Alexandra say this? Well, it turned out that she had been an intern in a patient support program that I run at the University of California Medical Center. And this is a story from the Wall Street Journal. This is a picture of Alexandra working with one of our physicians and one of our patients. And I train student interns to be health coaches and to help patients reflect critically on the decisions that they're going through, usually about cancer, but also in other specialty conditions. And as part of that critical reflection, my health coaches administer some of the tools and techniques that I've come up with over the years of working in this field. So I should go back for a minute and explain how I got into this. When I was about Alexandra's age, in my mid-20s, I was studying to get a PhD in engineering at Stanford. And I was studying systems engineering, and within that discipline, I was studying decision and risk analysis. And this is the kind of study where engineers, every engineering school, will have this kind of program because engineers are always designing systems that involve trade-offs. So for example, if you're building a bridge, just to use kind of a classic example, there's going to be issues around the cost of the bridge and the weight and how it responds to wind shear forces. And in San Francisco, where I'm from, the seismic issues. And then there's the aesthetics. So all these things have to be designed and traded off. And that's why engineers pay close attention to this kind of thing. So I was studying decision and risk analysis, but I fell in with a group of medical doctors. And they said, this is exactly the kind of thinking we need more of in healthcare. So they convinced me to focus my PhD dissertation work on medical decision making. And in particular, they suggested that I should use my quantitative background, all my training in engineering, to build models and help patients and doctors figure out what they needed to do. I had the good sense and the good training to realize that actually probably what was really needed here was some ethnographic work, was to spend time with patients and figure out what their needs really were. I had teachers who really emphasized a discipline called action science. And one of the messages I took away from that was that quality is qualitative. That's why it's called quality. Otherwise, it would be called quantity. So I joined a resource center that was just starting up in Palo Alto that was focused on putting together a support system for people who were newly diagnosed with breast cancer. This was an organization founded by breast cancer survivors who were committed to building a health library and having a buddy system and really educating and informing and involving newly diagnosed patients in their care. So I joined this organization, and I was kind of the odd man out, literally. So one of the volunteers, a really fierce advocate, said to me, "We don't know quite what to make of you, Jeff. You have 4 strikes against you. First of all, you're male. Second, you've never had breast cancer. Third, you're young. And fourth, you're an engineer. And we can't decide which is the worst thing." But actually, these 4 strikes were kind of a blessing in disguise because I knew that I didn't know anything. And I knew I needed to do this kind of qualitative field work. And so I started volunteering. I took the action science kind of credo of learning by helping. And I started seeing what I could do around the resource center to help. And as it turned out, there were some very common sense things, like women or anyone newly diagnosed with cancer or any kind of serious diagnosis often go to appointments and freeze up and forget to ask questions that have been keeping them awake at night, and then also can't absorb all the information that they're getting. It goes in one ear and out the other. So I volunteered to go as a note taker to these appointments, and I would help people make a list of questions beforehand, and then I would go with them and type up notes and give them copies of the notes and recordings that I made. And I did this with 132 women and their families, going from talking to them beforehand to the waiting room, into the exam room with surgeons and oncologists. And of course, the notes and the recordings were for the patients, but I also got permission to keep them and analyze them as part of my research. So I learned a lot, as you can imagine. And one of the things I learned is that people are really driven, their decisions are really driven by 5 decision drivers. These are sources of power and wisdom, but also can be sources of bias and kind of distorted decision making. So I'll run through them very quickly. The 5 drivers are, number 1, the somatic driver. This is our limbic system, the reptilian brain. This is us making decisions automatically and unconsciously. I think this has become familiar in the literature. There's a book called Thinking Fast and Slow by Tversky and Kahneman, or Kahneman, I should say, but building on the work of Tversky and Kahneman. So in medicine, this relates to people having, for example, a fight, flight, or freeze reaction when they're confronted with a diagnosis like cancer. And that can work in your favor, and it can also work against you, depending on how things play out. The second major driver is social. And when I say social, I don't just mean people, like you obviously go to a physician for advice and information, but also the whole social environment, the built environment, how we interact with nature, all of that, I'm putting that in this social category. In medicine, it's particularly telling that there's the spiritual dimension, people turning to prayer and to their religious leaders and to a higher power. And of course, that is a source of tremendous comfort to people. It can sometimes be a source of distorted decision-making. For example, if people end up having an overly fatalistic reaction and saying, I can't do anything about this, it's in God's hands. So each of these things can be a source for good or a source for bias. The 4th driver is soulful. This is identity-based decision-making. This is when you're making decisions based on your self-image, your actual self-image or your aspirations. And in medicine, we might see that as an example if people are either having surgeries or avoiding surgeries. because of something like their body image. And then finally, last and least, is the scientific driver for decision making. And I say this is last and least. Professionals gravitate most naturally to this one. This is the rational, deliberative, analytical, reductionist approach looking to data, and doctors, like other professionals, are very fond of this, and they'll lead with this kind of orientation, even when their clients, patients, are in the other realms. So this has been a very useful kind of diagnostic, and one way to think about it is in terms of checks and balances, to think about how can we get all of these things lining up so that we're making decisions with kind of the harmony of these influences. Or at least we can use them as checks and balances to help us reflect critically on decisions. That last one, the scientific driver, I'm not crazy about leading with that one, but it does have a real source of power if you use it to reflect critically on all 5 of the drivers. And so that was after now, getting out of my doctoral study and starting a patient support program with colleagues at the University of California, San Francisco. I was able to start to understand that what we needed to do was help patients and doctors reflect critically. And I found that there were, again, this is a very simple model that took me a very long time to come up with. I found that there were 4 strategies for critical reflection: thinking, talking, reading, and writing. So thinking, we all do that. Sometimes, though, we lie awake and our thoughts spin and we're not converging anywhere as we're reflecting critically on our decisions. So then we want to talk about the decisions. I had a boss who used to be an engineering manager at a firm where he would put a stuffed monkey in the corner of the engineering room, and he would tell his engineers, do not go bother another engineer with your problem until you've gone and told it to the monkey. And 9 times out of 10, the engineer would go over and verbalize the problem to the monkey and realize, what the solution was. So there's incredible power in thinking out loud, and then you can also, get advice and wisdom from people if you are interacting with them. So when I say talking, I also mean listening. The third strategy is reading, and when I say reading, I mean research in general, getting on the internet or whatever other sources of research we have and looking at things, text, audio, visual materials, whatever we can get out there. This one is pretty neglected. I find that people sometimes fail to do due diligence on major decisions in their lives, including medical decisions. So you want to balance these, thinking, talking, reading, and then the last one is almost completely neglected, and that's writing about your decisions. So doing all 4 of these is important, and as part of my research, I figured out that it was important to do the last especially. So I developed a technique called scoped, and this is what Alexandra used to reflect critically on her decision, and I'll get back to that in a minute. Scoped stands for situation, choices, objectives, people, evaluation, and decisions. It's a checklist. It's a way of going through the critical factors in a decision and making sure you're reflecting critically in writing and really accessing the power of those 5 S's we looked at earlier: the somatic, the social, the soulful, the spiritual, and the scientific. So let me walk you through, and you're going to have a handout at the end of this session that will give you what I call a scoped note. Alexandra filled out a template. These templates are accessible if you're using for non-commercial purposes. You can use them for free on my website, scope.org. And you go through and you just write about your decision. And in Alexandra's case, she needed to write 3 key facts about her situation. Well, she had a cardiac arrest. There might have been this genetic component, long QT syndrome, and she has a family history of breast cancer. These are 3 key facts about the past leading to the present that kind of set up the need for a decision. The second section is choices. This is where you just brainstorm what is the spectrum of choices that is available. Often there's a minimally invasive choice in any discipline or any field. There's a maximally invasive or aggressive choice, and maybe something in the middle. So starting with 3 is a good idea just to kind of stretch the canvas. In Alexandra's case, she wanted to look at implanting a defibrillator, and there are 2 ways that could be done, or taking her chances and not having a defibrillator implanted. In the choices section, it's like brainstorming. You don't evaluate yet. You're just kind of getting clear on what is available. Then in the objectives, you want to list your priorities, ideally in order of importance, and for Alexandra, pretty clearly, preventing future cardiac arrest, minimizing complications. And then, because she's 20, she wants to really make sure that she's not really scarred cosmetically by this. The implantation of a defibrillator can create this deformity in the chest. So, naturally, there's a question there about scarring and cosmetic issues. Then we go to the people section, and here's where you just list some of the people or stakeholders that are involved or affected in the decision. In this case, Alexandra and her family and her medical care team. And you get to kind of the heart of the scope process, which is building an evaluation table. This is like a times table where you got the choices and you're crossing them with the objectives. And in each intersection of choice and objective, you're writing the results of your research and your thinking and your talking, your reading and writing, and you're putting it in there. And when Alexandra did this, she realized that she'd had a lot of good information from her doctors on her highest priority issue with the third choice, no defibrillator. So they had told her, look, this could be really mortal. You have a 13% chance of dying before the age 40, according to all of the data. But interestingly, they hadn't really told her how much or very much detail about how her chances would be improved with the other choices. So she put question marks in that column for those choices. And when you're making decisions and using scopes, putting question marks or leaving blanks, that's a sign that this is an information sweet spot where you can go do some more of that thinking, talking, and reading and writing and reflect critically on that. And in fact, that's what Alexandra did. I won't go through the whole table again. You'll have it in a handout shortly. But what she ultimately decided was that she talked to her doctors and figured out that they could go back to a procedure that they really had abandoned 10 or 15 years earlier because it wasn't so suitable for the older patients that they were doing it on. On the other hand, putting this defibrillator under the muscle was pretty ideal for someone as healthy and young and vibrant as Alexandra. She could recover from doing the rehab and the shoulder exercises and all that kind of thing. And putting it under the muscle would sort of hide this deck of cards under the muscle where it didn't protrude. And I think there was also less scarring and that sort of thing. So she decided on that as the best choice and went with genetic testing as a next step. So Alexandra went on to get a scholarship to medical school, and she's now a resident in general internal medicine at UCLA. And she may end up focusing on this kind of cardiac area because, like many people, there's this kind of wounded healer model where when something has affected you this profoundly, you want to do something about it for the rest of the world as well. She's incredibly inspiring to me. I'm in very close touch with her. And I recently asked her, so how's it going? How's that defibrillator working out? And what's next? And she said, well, the good news is that the defibrillator hasn't gone off at all in the last few years. But that does make me question whether I really need it. And so I'm going to be facing a decision in a few years when they decide to remove the defibrillator to change the batteries. Am I going to want to put it back in? And once again, she totally touched my heart and said, thanks to you, I know exactly how I'm going to make that decision. And now I hope, so do you. Thanks a lot.